Hi, I'm Dr. Courtney Washington, board-certified family medicine physician, owner and CEO of Fleur de Lis Primary Care Clinic. And today we have a guest. Her name is Dr. Mia Weber.
I am Dr. Mia Weber, board-certified pediatrician. I am owner and physician at Leap Pediatrics Clinic in Harvey, Louisiana. I am born and raised in New Orleans. I went to Xavier University,
Whoop.
trained at LSU,
Let's go.
and did my residency at Children's Hospital of New Orleans.
Awesome. So today we are going to discuss when to go to your primary care physician or the pediatrician versus urgent care versus ER. I work in the ER a lot. I've worked in urgent care in Fort Worth and Dallas, and I've been all around. So I see this kind of confused a lot, and I want to save you guys time and get you the best treatment. So we are going to talk about the most common things that we see our patients go to the ER for that could be handled by us. So the first one we're going to talk about is fever. So from an adult standpoint, if you just started getting a fever, it really depends on your age, your medical history, immune competence. If you have cancer going through chemo, there's a whole bunch of reasons you can have a fever. But for most of us that are normally healthy, if you have new onset fever, it's probably viral. And there's more viruses than just COVID. So when we talk about the common cold, there's a whole host of rhinoviruses. So usually that's not a reason to go to the ER. Try over-the-counter medications first, and then your primary care physician is going to be the best person to kind of work that fever up. Most of the time it's viral, and viruses do not, I repeat, viruses do not need antibiotics. And I will let the pediatrician tell you about the peds.
Yes, for pediatrics, neonatal fevers or fever in a baby under 1 month is really the only medical emergency that we worry about, unless there are some other symptoms that are going along with it that make the baby or the child have problems. So for the most part, a fever is considered over 100.4. So that's 100.5 and up. If you have a thermometer, you would know that subjective fevers usually are just subjective fevers. You can have a febrile seizure if the fever rises quickly. It's not according to how high the fever is. So even a fever of 103 or 104 can be handled in your doctor's office. It doesn't necessarily have to go to the ER.
Absolutely. And the subjective fevers, thermometers, they sell them at the dollar store. It's very, very important, especially for those kiddos that are less than 1 month. I need to know the number. So subjective fever doesn't help us a lot because that's going to determine whether I need to transfer this baby to Children's Hospital and get a workup, which includes a spinal tap because it could be meningitis. So we really need to know that number. Giving antibiotics when you don't have a bacterial infection is actually detrimental to your normal flora of your gut. So we have a whole host of bacteria that protect us from the bad bacteria that you kill off when you take antibiotics. It leads to antibiotic resistance by bacteria. Bacteria reproduce rapidly. So the more that you use those antibiotics, the bacteria will become resistant, and when you really do need it, they won't work.
Fever is a generalized symptom, so sometimes it can be coupled with bacterial infections, but the doctor would need to see that. And I'm saying that to say, trust your doctor.
Amen.
Trust your doctor. Don't always go to the emergency room. It's okay to call your physician and tell them the other symptoms because they have the wheelhouse to know what diseases could go with that symptomology. So trust your doctor. The ER doctors are great, but continuity of care and knowing who your physician knowing who you are and what your baby normally gets is important as well.
Find a doctor that you trust, right? Mm-hmm. So it's all about trust. This is a relationship, right? So if you are going to a doctor as an adult or if you're a pediatrician and you don't feel comfortable, then it might not be the right patient-doctor relationship. So every time that I discharge a patient, I'm like, follow up with your primary care or follow up with the pediatrician. Like, oh, well, I like you better. Then find a pediatrician that you like and you can speak to.
Yes.
Our next most common thing that I see in pediatrics is going to be diarrhea, and I see it in adults too. For adults, diarrhea, again, most of the time is going to be viral. Unless you went to a huge outdoor concert and happen to drink the well water, I do not need a stool sample. I repeat, please do not bring me your stool, okay? So it's usually...
You don't want to see it.
No, I don't want to see it. I take your word for it. No, don't show me pictures. I don't need to see it, okay? So most of the time it's going to be viral, and they do have over-the-counter things like Imodium AD. The biggest thing is going to be definitely see your primary care physician that knows all of your past medical history. Imodium is probably what I'm going to prescribe, or I may prescribe Lomoto is what I prescribe for resistant diarrhea. So a lot of the time, just remain hydrated, right? Stay on top of the fever with Tylenol. Please do not just have a fever, adults, for as 104 for 4 days. That's not a good thing. Remember that water boils at 100 degrees, right? So if you're having a fever of 104, you're basically vaporizing all of your fluids and you're dehydrating yourself. And that can lead to an acute kidney injury, and then you can get really, really sick. So definitely see your primary care doctor based upon your history. It might be a UTI, it might be other things. I don't know, but definitely see me. If it is the weekend and let's say you really feel like the diarrhea is becoming too much, Imodium isn't working, depends on your medical history, and please consult with your physician. These are general recommendations, right? Urgent care is fine, but again, your primary care doctor is going to be a better alternative because they know you and they know your medical history. And urgent care, maybe plus or minus. ER, definitely not. The only time to go to the ER for diarrhea would be if you see massive amounts of blood in your stool. Massive amounts. This has been going on all day, then yes, please go to the ER. That is an emergency because you could be hemorrhaging. We don't know. So pediatric version of diarrhea.
Pediatric version of diarrhea. Well, I'm a bit of a specialist in poop because I see a lot of diapers. Babies do have frequent stooling, and it is looser. So in babies, we expect them to have loose stools. There's a difference between diarrhea and loose stooling in babies. Sometimes babies can have a bit of a blood streak in their stools when they have diarrhea and when they have malabsorption of formula. But that's not an emergency. That's something that your pediatrician can handle. Diarrhea, we do not stop. We don't give Lomoto or Imodium often, maybe for the older kids, but not for the younger ones. We feed them through it. If they can maintain their fluid intake, then we just give them what they need. Brat diet, bland things, nothing too spicy. Don't do red things because it can scare you if it come out the other end really fast. But we do give Pedialyte temporarily, but we start those calories going over the next day or so. We don't want 3 days of Pedialyte. Parents tend to think that it's okay, but Pedialyte doesn't have calories. We still need to feed the kids, and so they won't become lethargic. But an emergency would be diarrhea and dehydration, less tears, the child looks lethargic, and things like that. So.
And then at what age would we do Lomoto for pediatric patients?
I would say over 12 years old for the most part, but most times I've never had to do that. If they just keep up with the brat diet, we give them some Zofran to help settle their stomach. It's very rare that we give Imodium, partly because kids can be poor historians and then they get bloated, and the Lomoto can also cause some cramping as well.
Yes.
So we tend to not want to do harm. So we tend to say, feed the baby, give them some, bulking, some starchy stuff like mashed potatoes, bread, rice, crackers, and brothy things, clear fluids, and they tend to do okay.
Absolutely. And pay attention to the age on these medications. A lot of the times the over-the-counter medications, if it says for children 6 and above, that's what it means. Pediatrics, a lot of the times I see patients that come into the ER and say they're 2. And then it's like, oh, well, I did give them Mucinex, and they have these rashes. I mean, they can get very sick. And the main thing is that younger kids, their liver is very immature, so they do not have the enzymes to break it down. So it builds up and it becomes a toxin. And this could be very life-threatening, especially with things like aspirin for kids. That is a no-no unless specifically directed by a doctor. Any other warning sign medications?
Well, the medication says speak to your doctor for a reason. And so you should not be dosing your own child. Children have a different body composition of fat, so things clear a little differently from them. Even topical things can clear differently with kids. So you don't just go put homeopathic medicines on children. You don't give them the essential oils because it can intoxicate them a little longer and more so than adults.
Absolutely. That's a great point. Great point. Our third most common thing that I see in the ER is a rash. So adults and rashes. It definitely is going to depend on your medical history. A rash that is an emergency type of rash is one that is widespread. The most life-threatening one I could think of is Steven Johnson syndrome. And that one is a life-threatening emergency. It usually is secondary to some type of antibiotic or something going on. But that one, if you have a widespread rash, it looks like blisters and it's everywhere, that is an emergency. Definitely come for that. Other rashes that have been there for a few days and say, it's just starting to bother you on the weekend, wait to see your primary care doctor. It could be a whole bunch of things, but the ER is really for life-threatening emergencies. And when in doubt, most physicians do have an after-hours number, and someone is always checking it. So if it sounds very suspicious, your primary care can call you back for that. So it's in second opinions in the ER. ER physicians are trained for emergencies, right? So the specialist is the person that sees these things more often. So in my primary care practice, I see way more rashes than my counterparts who are board certified ER physicians. Not saying that they may not know it, but it may not be as readily rememberable, as so to say. So rashes are usually not life-threatening with the exception of some. If it is life-threatening and you leave a message for your primary care doctor, usually they'll call you back. And if they feel like it's life-threatening, they'll tell you to go to the ER. And a lot of the times, if I'm telling my patient to go to the ER, I've called the ER and given them a heads up with their medical history, like, hey, this is what I'm concerned about, so that you're not just sitting there waiting 4, 5, 6 hours and they have gunshot wounds in the back. Yeah, it's not an emergency. So peds.
Well, peds with rashes, history is important. Symptomology coupled with the rash is important. What symptoms are related? And a picture and those symptoms on the phone can be perfectly fine for a pediatrician to diagnose whatever rash your child has, or even a primary care doctor. We do virtuals. We can see rashes and diagnose them by phone and by virtual visits as well. So you don't have to go to the ER. You can request a virtual visit or a telephone call the next day.
Absolutely. Another rash that is concerning, though, is for shingles. Shingles rash, especially if it is in this area. Now, I would say probably ER for that, because those blisters can be on your cornea and you can lose vision, especially in pediatrics. So it depends on where it is. But again, if you have that symptom and it happens to be a Saturday, urgent care should be able to recognize that immediately. Or you can call your primary and they can kind of handle that and figure out where to triage and tell you to go. But most of the time, a rash is something that we are very capable of handling. And if it needs to be seen by a dermatologist, we can refer.
And shingles is very, very rare in pediatrics. We do give vaccines, and sometimes you can actually get shingles around the vaccine spot, but rarely do I see shingles. Newborns that have shingles because they've been exposed to it, that does happen. So that is an emergency.
The fourth most common thing that I see is fractures. For adults, and this is for peds too, and I'll let Dr. Weber kind of go more into this with peds. So when I worked in urgent care, I would see a lot of patients that come to the urgent care for fractures. A lot of the times, if it's non-displaced, meaning that the bone is in anatomical alignment, the only way that I know that it's broke is that you said you fell, off the roof and you came in and I did an x-ray and I'm like, oh, wow, it's broken. Those I can kind of put in a sling and manage. Ortho follow-up, because there's no urgent reason to take you to the OR. If you have a fracture and the joint or the bone is not in anatomical alignment, meaning it's deformed, if your wrist is over here, that's a problem. Do not come to the urgent care with that. All I have is an x-ray machine, and I am not a surgeon. They don't have surgeons in urgent care. That is ER. And a lot of the times you have very important nerves and vasculature, and those could be compromised if you waste time going to an urgent care. You need to be in an ER, and we need to call a surgeon, because you can lose the function of your hand or some other part of your body from a fracture that bad. Also, if you see bone sticking out, that is a compound fracture. The ER, I cannot help you. Your primary care cannot help you in that situation. Right. That is an emergency. That is a point to where you definitely want to go. So pediatric version on
Pediatric version, kids are just busy. Kids like to climb, they like to jump, they like to run, and they get abused. So we do see fractures in pediatrics. Now, if it's displaced, definitely you need to go to the ER. If you see where the fingers look deformed or the arm looks deformed, then that's an ER visit. Now, a lot of times kids that are young may just fall on their outstretched arms. It's very rare for a child under 4 years old to actually cause their own fracture. Kids are kind of made to bump and bruise and bend, and they do bruise, but they don't necessarily fracture themselves. Now, if they fell from a 2-story building, that's a bit of negligence. That's a bit more involved. They should go to the ER. They fell downstairs, they should go to the ER. But most kids tend to have sprains, but most kids don't fracture themselves unless somebody else is involved, like a parent steps on them or drops them or abuses them. As far as older kids, they tend to get sprains and fractures as well. So again, I agree with what you're saying for the older children. Their bones are more mineralized and it's not as bendy. So we would have to do x-rays to see if it really needs to be treated.
And that brings me to another thing that I wanted to address as well. CT scans on children. So falls. Pediatrics, most of the time we don't want to CT scan a baby. We don't. That is radiation, and we have to have a really good reason to do that. Physical exams are going to be very, very important. So say, for instance, your child, you're at the grocery store, say they're 3. They stand up in the basket, they fall onto their head off the basket, right? So they come into the ER. I'm always going to do a neurological exam, things like that. I would do an x-ray, but CT scanning, you're always going to want to be very, very cautious when you do that. Pediatric recommendations for it.
Well, first of all, kids need to sit still and they don't. So you would be putting your kids to sleep in order to do that scan for the most part. Rarely do they let the kids stay awake for a CT scan. And head injuries, minor head injuries do happen. And I hate to say it like that, but kids are like basketballs and older people are like bowling balls. So when we hit the ground, we hit hard. When they hit the ground, they kind of bounce. They have air cells around their brain. So their brain is kind of made to have some accidents, but I wouldn't say that we shouldn't examine them and make sure that they're okay. But kids do have fall injuries that don't result in brain injury as much as adults do.
Absolutely. And if your kid has a fall, say they fell and you didn't see it, but they have a knot. If your kid starts to vomit after that a lot, not just once, but vomit a lot, they're very, very lethargic, can't wake them up, that is an ER call. That is not an urgent care call. That's an ER call. And preferably, if you have 2 hospitals and there's a pediatric hospital, please take them to the pediatric hospital. Don't pass it up and say, oh, the line is long. No, when there's an emergency, we triage. So when I'm working the ER, I'm looking at the board. If I see kid lethargic, vomited times 5, and I'm seeing that kid first before the rash.
Yes.
Okay, so that is an ER visit. So it really depends. Watch that kid, especially after a fall, and watch him with caution, and you'll know where to go. And if you're unsure, you can always still call your pediatrician or your primary care. We have after hours services. So that would be what I say about that. And again, CT scans, we don't do that lightly in kids. And in adults, we don't routinely just CT your head either, unless we have a really, really good reason to, because it is, number 1, it takes a long time. Number 2, radiation, more radiation. Sutures, cuts, and more cuts. All right. So sometimes in the primary care sector, I can do sutures, but most of the time during the day, these are scheduled visits. Urgent care is very capable of doing minor lacerations. A minor laceration is, say, like you were chopping something and you cut your finger with the knife, right? So if you don't see the bone, cool, that's fine. If you, say, got into an altercation and you grab the blade of a knife and it is squirting out, that's more of an ER thing. If you can see the bone and if you see like it is squirting, that may have to be surgically taken care of. Another thing, another place where if you get a laceration, you want to go to the ER is the eyelid. The eyelid, you have 3 different types of skin there. So sometimes you may need a plastic surgeon to close that. Things that are deep cuts on the face. The face is very, very vascular, very, very opportunistic place to where you can get infections that may spread to the brain and lead to complications. So usually in the ER, the urgent care, we don't want to handle that. Sometimes that may have to go to the ER and go to the OR to have it very well cleaned out. So recap, if you see the bone, that's an ER stitch, right? If you have a long laceration, that's the ER. So if anything other than something that's minor, I wouldn't say anything longer than maybe 4 inches. And if you see,
what do you guys do about teeth? Missing teeth.
Missing teeth. So it depends, right? And it depends on the age. It depends on the age. So that gets complicated. Missing teeth, if it's freshly knocked out and you can see the root, right? Yes. So you see the root. You pick that tooth up, right? If this is a football injury or something like that, they usually have it. They can put it in milk or something like that. I just put it back in the socket. If the tooth has been in half and you can see the pulp, which is like the middle of the tooth, that's a dentist. I can't do anything about that. Yeah. I've had a kid that fell on the stairs and basically the tooth went into the gums. Face. I can't fix that in the ER. We're not dentists. And that brings me to dental pain. That's my pet peeve. Dental pain. We're not dentists. Dentists go to dental school. So if you have an abscess in your mouth or something like that, I don't know how to pull a tooth. I could go get the pliers, but you wouldn't want me to do that, okay? So I'm not dentist. The only time that we can call a maxillofacial surgeon is if there is a tooth abscess and it is huge. It can spread to the brain, so that is a life-threatening emergency. Maxillofacial will come out for that. But other than that, if it's like a cavity or you need a root canal, or even if the tooth is kind of jammed up a little bit, not a super big emergency and they're not going to come out, you'll have to follow up with the dentist when they're open.
For pediatrics, you treat it differently based on if it's a primary tooth or if it's the permanent tooth. So I guess with kids that I've had a lot of kids push their teeth back in, they thought they could fly and they put it on their face. That happens quite often in pediatrics. Sometimes we save the teeth, sometimes they don't. If it's a football injury, as you said, you could put it back in if you see the root, put it in milk and go straight to your emergency room so somebody can put that in within a couple of hours. As far as lacerations, within 6 hours, they need to be repaired. With kids, we do recommend, if it's on the face, a plastic surgeon or somebody that can do a really nice suture, or somebody that has good experience with that. Sometimes Dermabond is used as well. Again, the child would need to be held down, sometimes sedated a little bit, sometimes the papoose board, a lot of screaming, a lot of tearing up, but that happens. But ER for lacerations that are needing to be sutured.
Our last topic is going to be dysuria in females or males. So I'll start with the adults. So dysuria is basically painful urination, right? And if we're talking about females versus males, because it makes a difference. For females, our urethra is shorter than males, so more commonly getting UTIs. A lot of the time it's going to be due to E. coli because you have to wipe from front to back. If you wipe from back to front, some fecal matter can get into the vagina or get into the urethra, and then the E. coli climbs up and it causes an infection, and if left untreated, it can go all the way up to the kidney and cause pyelonephritis, which is an infection of the kidney, which can be pretty bad. So that's usually the cause of female UTIs. As we get a little bit older, our immune system is not as robust. So in the elderly or geriatric population, we do see more commonly UTIs, and that can lead to urosepsis, where the bacteria that was causing the infection in the bladder actually gets into the bloodstream, and that is a life-threatening emergency. So if you do have dysuria, you always don't wait and take AZO, please. If it's during the weekday, please make an appointment with your primary care provider, and they can find a way to fit you in. And if they can't fit you in, sometimes they can start empiric antibiotics, and it really depends on if this is a recurrent UTI or not. We don't usually like to start empiric antibiotics unless it's over the weekend or something like that, because we want a urine culture. If we start you on antibiotics, we don't know what bacteria it is. We don't know what it's sensitive to. And the more that we treat empirically, the more resistant those bacteria get. So that is a primary care type of visit, or if it's on the weekend, and especially if you're elderly, that's perfectly fine for urgent care, so that you can be seen, they can get a urine culture and give you antibiotics for it. And if you continue to get frequent urinary tract infections, we would at some point refer you to a urologist to make sure that the valves are working and that you're not getting reflux or something interesting is happening. For males who get UTIs, any male that gets a UTI, that is always going to be a complicated UTI because the male urethra is so much longer. So it's not, something is going on that shouldn't be to where a male is getting a UTI. So we're going to treat that differently. We're always going to want a urine culture if possible, but especially for my elderly population or immunocompromised, if you're on things like Humira or chemo or something like that, we really do want that to be treated. So that is an urgent care type of visit. If you've been having dysuria or painful urination for quite some time and you're starting to get fever, chills, you feel really sick, now that may be an ER visit. But you can always still call your primary care doctor. If you don't have one, get one, and they'll recommend where you should go with that. Now let Dr. Weber talk about the pediatric UTIs.
I actually see many UTIs in girls, especially young girls that are starting to potty train and take over 4 years old about, because I think the schools are now telling the kids that they have to do it all on their own. And it's because they don't wipe correctly and appropriately, and they also have a bunch of other things like vaginitis. They tend to sit on the toilet like princesses. They wipe the wrong way. So we do get about 3 or 4 little girls that come in with common UTIs. The next age is when they become sexually active. You know when your daughter is sexually active because she definitely gets a UTI the first time or first couple of times. So that's my other wave of patients that get it. And of course, some of these young ladies don't wipe the right way either. They don't know how to clean and appropriately take care of themselves after that. So UTIs are very common in the young girls. The boys get them as well. But not as often as you said before. It's more complicated. I do have kids that come in, and one of the things we check every time they pee in the bed is for a UTI, because sometimes kids are just not good historians. They sometimes live with this, enuresis, and you don't understand why until you check. I have little boys that do that, and sometimes it starts off with constipation that leads for them to have enuresis. So we treat that as well. Like you said, all antibiotics aren't created equal. We want to get some urine and test it to make sure that we're treating it appropriately as well. And we want to recheck for little kids that it's gone away, because they're not going to tell you, hey, I feel a UTI again. So that's important. Going to the ER for those things, for high fevers, if they have like back pain, little girls that have Fitzhugh-Curtis, or they have chlamydia, gonorrhea, along with that dysuria. Boys sometimes can have that as well. And so those are not emergencies, but if it's something that's causing them extreme abdominal pain, or we call it they're doing an abdominal shuffle with it. Yeah, the ER is warranted. Yeah.
Absolutely. So I hope this really gave you guys a good overview of when to see your primary care physician or your pediatrician versus the ER versus urgent care. So just to summarize, we know our patients a whole lot more. It's a whole lot more intimate type of relationship. Most of my patients, I know their medical history, I know them. So it's better treatment because I'm going from a different lens. I would treat that patient, or what treatment is going to be appropriate, because say if, for example, I have a patient that's on Humira for psoriatic arthritis, right? And they're coming in with dysuria. That would probably definitely change my course of action of what antibiotic I would pick based upon their medical history. And that's kind of hard sometimes to get in the ER when so many things are going on. And then if I get a sample and I send it off for culture in the ER, the follow-up. ER physicians, we work in shifts, right? So it's not going to be the same person. So it's not going to be a good continuity of care. So we're almost like the specialists when it comes to overall triaging and figuring out what is going to be the best plan of treatment for you. ER is for emergencies. They are trained to put out fires. We are for the person that comes in with a gunshot wound, or if this person needs to be admitted to a hospital for something emergently. So that's why a lot of the times patients get a little frustrated when there's a long wait. But what you don't see is there's trauma that's coming in. There's somebody that we're intubating. There are complex lacerations. And so even though UTIs is painful, it's not pleasant, but someone's dying or has just died in the back. So be patient with us. We're human too, and we get sick too. We both are moms and we have little babies, and we've been on the opposite side of this. I never I'm a doctor, see me first. We don't do that because that's just so disrespectful, and that's just not the way the world works. The urgent care, I like it. It's a cool little niche. I mean, it's for urgent things that are not super major things. Most urgent cares only have an x-ray machine, and some of them don't really have much in the way of staff. It's for very, very basic things. Do you think you have the flu and you want a flu test? Knock yourself out, right? Like strep.
Yeah.
Things like that. If this is a complex rash and you've been to every specialist in the world and you want a second opinion from urgent care or ER, baby, we not the ones. We sending you to a specialist, right? So this is like the gateway into these specialists.
Trust your doctor. Your doctor is extremely important. The urgent care, the ER, and your Google search, as well as the labels on the medication say, consult with your physician. So it's always good to have a primary care doctor in that sense, and they can tell you which specialist to go to. Because I have had some patients that have referred themselves to 4 and 5 specialists, and they weren't equipped to pinpoint exactly what was going on with their child. You have to do some preliminary tests first to see where you need to go next, and there's a step process. So, and you don't want to do invasive stuff to your kids. You're sending them to a GI to be scoped. You're sending them to a respiratory therapist to get this tube, the ENT to get this procedure. And those specialists are basically, they specialize in doing procedures. Correct. Some of those procedures are invasive. The general doctor tells you what they think you need to prevent you from doing unnecessary procedures on your child or yourself.
Absolutely, because there's an overlap. For example, if I have a kid that's, say, 10 years old and is having enuresis, right? The first thing I'm doing is not referring to a urologist. I'm going to do a whole lot of digging in background first. Is this kid being bullied? Is this kid nervous? Was there a recent divorce? Sometimes it can be psychological, and they may need a psychologist or a psychiatrist other than a urologist who may end up doing a cystoscope or something invasive. So that's why you have to trust your doctor, because there is a lot of overlap when it comes to specialists. And we always want to go least invasive to most invasive. And I leave that for a step up. Another thing is when it comes to adults with, say, for instance, back pain, right? I always tell patients when I'm in the ER, back pain is not just back pain. It could be rheumatological. It could be a malignant tumor that's compressing on the nerves. It could be multiple myeloma, which is a form of cancer. Don't just make an appointment with the orthopedic surgeon. They're not going to be thinking that way, because most of the time they're referred, so they've been screened by a physician. So when I refer a patient to orthopedic surgery, I've already done x-rays. Sometimes I may have even ordered an MRI, and I'm like, oh, this guy has spinal stenosis, which means that they have arthritis in the central canal of their vertebra, and it's pressing on their spinal cord. So we know that probably they need a laminectomy, which is they take a part of the bone to relieve that pressure, right? So that's what they're expecting. So when you make an appointment with the orthopedic surgeon because you have back pain and you don't have any x-rays, you don't have anything, this could be lupus, it could be a whole bunch of host of things, but that's not what they're going to be looking for, and you're actually delaying the proper diagnosis and may get unnecessary procedures that you don't need because Google is not as equipped as our medical degrees. We study this stuff, we eat, live, and breathe it, we read the updated stuff. Like we are thinking with you, we're teasing out every little thing. And when I refer you to a surgeon, they are surgeons. So you probably need surgery. I'm not usually referring to a surgeon unless I feel like you need surgery, and we talk about it because surgery is always a life or death situation. It's anesthesia, it's recovery, it's all of those things, and we leave those last, because once you cut, you've been cut, right?
Right.
So
definitely.
And we know that we have our team of surgeons that are and other specialists that know and are more experienced in certain aspects with certain patients. And also it's about the personality, right? Certain surgeons or specialists kind of would be more of a better fit for certain patients. As a medical community, we're pretty tight. We see each other a lot. We work with each other a lot. And we always try to pick the best specialist that's going to understand your specific need. And also it's about a trust factor, how that person would engage with you. So trust us. Talk to
Trust us, and we trust certain specialists. And they call us and they say, "Why'd you send this patient to me again?" You'd be like, "Why is that patient going to you? I don't know who sent that patient to you." Or they'll call you and say, "I think you should check this," or "I'm sending them back to you because I don't feel like they need to be seen by me." And so we do, like she said, like Dr. Washington said, we talk to the specialist. When we're concerned enough to send you to somebody to get a procedure, we pick up the phone and we take their advice very seriously, and we expect the patients to take our advice seriously as well, because it's a team effort, you know.
It really is. It really is. So I hope that this was informative. We love medicine. We love our patients, and we really do love what we do. Yes. Like, I get excited reading about this, and I love seeing great outcomes, and it always makes me sad when I do get new patients, or even my old patients that cheat on me and go to the ER for something, and then it was the wrong thing. It's like, baby, come on over here. So we will be doing this more. Please comment below. Follow us on our social medias. I have them listed below. Again, this is general advice. Please see your personal physician to discuss your personal needs. But we want to hear from you guys, and we want to give you guys some of the knowledge that we have amassed over all of these years of education and learning.
And time, yeah. It's been a long time.
Oh, Lord, a long time. All right, guys. Well, thanks for joining us, and you guys enjoy yourselves and be safe out here.
Thanks. Bye-bye.